All right, we're 3 minutes after. We have, I guess, to start term. Good morning, welcome. Thank you so much for being here in person. My name is Alex Caldwell. I'm the director of the Center for Health Affordability. Congratulations, Serena. Thank you for being here in person. We have a full day planned for you today. And I want to make sure that we're sounding okay to the folks online. Jessica, can you give us a thumbs up or maybe come off mute so we can hear how clear the audio is? Thumbs up. All right, people can hear us. Jessica?
Yes, it sounds clear. Thank you.
Okay, that's a demonstration because everybody's voices are like perfectly clear on this audio system, thanks to you, Rock. But it means that if you're having a conversation, you can be heard by everybody online. So that's nice because it means we don't have to yell, but it also means everybody's conversations are just online. So I just wanted to be aware of that. I want to thank I think we have something like 50 some people logged in online. We have lots of people listening in today. We have Care Levin here today. So just to say thanks again for your time. This is not easy work and it's on top of your day job on a beautiful Friday. And so I just want to thank you for being here. Next slide, Jessica. Actually go 2 ahead, sorry. So thanks for going through this. I started my career as a teacher, so I'm kind of thinking in that mode. And one of the things that is really fun about sort of getting groups together is to build sort of a shared understanding of why we're here. And so that's our purpose of today. If you go back one, Jessica, there's 3 things that we want to be doing with you, and you have these on your agenda as well. One is just to create a sense of why we're here. What is the center? And what's your opportunity as the task force? We'll also do a bit of an introduction to what we know about high healthcare costs, and many folks are coming in with a lot of knowledge on that. Many folks are coming in with sort of a limited understanding of sort of the data landscape. So we're going to offer some of that and offer some initial or collect from you some initial guidance. So this is not about like, these are our 3 priorities, but just we want to hear your questions about where do you want to learn more? Because we know a lot in Minnesota about high healthcare spending and the impacts on individuals and on our employers and on our state budget. And so we'll spend some time there. And we want to, of course, build some urgency around the issue of healthcare affordability and high healthcare costs. Next slide. We have a full 3 hours booked with you, and I promise we won't go more than that. But we really want to spend most of our time today hearing from you all. So we'll do a bit of a welcome. We'll turn to you and spend some time just hearing more about the perspectives represented here. I'll share a little bit more about what to expect from the center, from this task force, what your role is, and that going forward. We'll take a break. And then we'll spend the second half of the meeting again looking at those data on what are the impacts of high healthcare costs and where do you want to learn more. So we'll have an opportunity for more discussion there. And then we'll close up and you can go on with your day. Next slide, please. A little bit of housekeeping. The slides will be available. Some people got copies, great. But that's just to save some trees. They're all available online. Or they will be available online as well as the recording of the meeting. So again, just for everyone's awareness for people who may not want their voices recorded, just be aware that if you want to have a conversation, I'm step outside. Bathrooms outside, right kind of here. You're welcome to pop out there whenever you need. And we ask the folks just remain on mute if you're online to just limit background noise. If you're having any tech problems for folks online, please do try logging back in, or you can also get in touch with us at health.affordability@state.mn.us. Again, meetings being recorded and closed captioning is available for folks online. So you should be able to go to the 3 dots at the top and you can start the transcription for folks online. All right, next slide. And here's where I'm going to turn to my colleague from the Minnesota Department of Health, Carol Backstrom. She is our Assistant Commissioner for our Health Systems Bureau. And I've asked her to just speak a little bit about the origin of the center, her ask for this group.
Thanks, Alex. I'm a projector, so I may not need a mic, but good morning. My name is Carol Backstrom. I'm the Assistant Commissioner for the Health Systems Bureau at the Department of Health, which includes the Health Regulation Division and the Health Policy Division. Congratulations to all of you on your appointment. Thank you for being here. On behalf of the Minnesota Department of Health, thank you for stepping up to do this work. We know that your time is valuable and the perspectives that you bring will be critical to the success of this effort. As you know, the Center for Healthcare Affordability was created by the Minnesota Legislature in 2023. It's the first time our legislature has created a permanent entity that's charged with understanding what's driving healthcare costs and what we can do to slow healthcare spending while maintaining access, quality, and equity. And it's more important than ever, as we know at this point, we have a long history of health reform task forces in the state. But for this time around, we actually have a permanent staffed legislative mandate in the Center for Healthcare Affordability. This also allows us to look at the evidence that we can look to from other states and looking at their progress and the way progress that they've made toward improving healthcare affordability for the residents. As we all know, and I can attest to personally at the Department of Health, we are facing federal funding cuts and have already experienced some of those. And that will likely result in thousands of Minnesotans losing their healthcare insurance coverage. And of course, with more people going without insurance, care will be less affordable for all. Hospitals will see sicker patients and will result in uncompensated care. And health insurance premiums for uninsured people are likely to go up, to continue to go up. And that applies to everyone, whether you get health insurance through your even if you get your health insurance through your job. We've needed a dedicated focus on affordability for a long time. And of course, these pressures are more pressing than ever. So asks of this task force, please bring your expertise and your personal experiences dealing with accessing affordable healthcare. Each of you brings a critical voice to this work. Be willing to think big. What can truly change the trajectory of healthcare costs in the state of Minnesota? And of course, we still need an element of pragmatism, given where we are today, and think about the steps we can take now to build toward longer-term change. Which groups should we focus on first? Lastly, importantly, bring the voices of your communities and networks, whether it's collecting stories from patients and networks, consumers and workers about the healthcare affordability challenges they face, or servicing the perspectives of employers and doctors and others seeking care to make care more affordable for their staff, patients, and communities. We are proud in Minnesota to have high coverage rates. We have high quality care, we have world-class innovation, but none of that matters if people can't afford to use the system. Thank you for your partnership in this effort. You are helping to shape policies that could make healthcare more affordable now, but also in the years to come for millions of Minnesotans. So thank you. Thanks, Alex.
Thank you, Carol. I'll try to face properly. I got a note that I need to face this way for people to hear me. So next slide, we're also dealing with like a little delay. So Jessica, thank you for your patience. Thanks everybody for your patience. It's always fun to do these hybrid meetings. I want to welcome this group. Thank you for your time. This is your task force. And I just want to recognize this is a competitive process. There are 40 some applicants, and we're just pleased to have that level of interest in Minnesota to do this work. It's not easy. We've had lots of different fits and starts in Minnesota on healthcare affordability issue, on addressing healthcare affordability. And so I'm excited to have this sort of dedicated, as Carol mentioned, first time really investing in this specific issue on a long-standing basis. A couple of the things to note here. One is I really want this group to show up as individual informed citizens in your own right. So you do not need to show up and represent your institution. You don't see any institutions listed here. That's on purpose. It's because each of you bring a perspective, both personal and a professional perspective, that I think is really important for the public to hear and for each other to share. So I just ask that, you don't need to show up with your institution in mind. You also don't need to show up with your seat in mind. That is really a function of how we recruited and built the group. So just be aware of, everyone here is a consumer, everyone here is a patient, and everyone here, brings different perspectives in terms of policy expertise and direction of what you want to see in terms of policy solutions. last thing I'll say about just who's in the room here is this group will be learning together. So you do not need to show up and say like, this is my proposed, I want to have this affordability plan that I want this group to, agree to. You may have your priors, everyone will, I know. But I don't think that, I don't want this group to show up and say everyone needs to sort of bring their own proposals. And instead, we're going to be bringing this group along and sort of some shared learning. This is where I'd like to turn to you all and offer you some time for introductions. And what I would ask is, take some time. If you go to the next slide, Jessica, there's some questions that I've asked this group to think a little bit about. And take, 2 minutes. It doesn't need to be 2 seconds. Don't take 10 minutes, but share a little bit about what brings you to commit your time and effort to this initiative. And optional second question, if you do have some asks or if you do have some sort of hopes for this group, I invite you to also share those. And I thought maybe we would start online. And Jamie, I had a note to myself to get in touch with you first to see if you'd be willing to do this. But we do have one task member that's joining us online today, given she's coming from a ways away. And Jamie, I wondered if you could come off mute and say hello to the group and begin our introduction.
Yeah, absolutely. Good morning, everybody. My name is Jamie Rancor. I live in the Mille Lacs area, and I'm so appreciative that you guys were able to accommodate my virtual attendance. Thank you so much for that. I'll start out with the first question. What led me to commit my time and expertise to this effort? Honestly, I feel like I'm a real person. I have experience as a MNsure navigator for about 5 years in that role, working with a tribal agency as well as Health Access Minnesota down in St. Paul. I've seen many things in that role. I've seen clients shed tears of joy, shed tears of excitement, and just feeling fortunate for the respective programs that they were eligible for. And that's hard. It's really hard to see people not be able to get care because it doesn't fit in their budget. I have also had personal experience. Both of my parents have had significant medical issues. Both are well below retirement age, and they are on disability because of those medical issues. As a youth, a child, I did not have doctor's appointments because we didn't have health insurance. It's all very personal to me. I'm a parent now. I work with children and families as well in a professional capacity. And I just want to do what's right for people in Minnesota. I have grandparents who actually just died pretty early in life. And if there's senior citizens in the state that can access healthcare to have a better quality of life and to live longer, be around for their family, I'm sorry I'm rambling now. It's just very personal. I'm going to stop it there, but thank you guys for having me.
Jamie, thank you. And just let us know if you want to be chiming in and we're not seeing you immediately. And if you have trouble hearing us, I just want to make sure you can hear us. So thank you for joining. Yeah, Jamie, so glad you're here. Thank you. And Matt, I wondered if we could just start on this end and kind of go around on Alpha and just go ahead and introduce yourself.
Sure. My name is Matt Anderson. I day job teach at the University of Minnesota in the Health Policy and Management Division of the School of Public Health. I'm not here representing the University of Minnesota. Please don't hold my opinions against the university. My background in healthcare is really, I spent about 14 years at the Minnesota Hospital Association, working in health policy and strategy, a lot of which was around either directly or indirectly around issues of affordability and payment models. And then before joining the university, I worked at the Minnesota Department of Human Services as Assistant Commissioner for Healthcare and State Medicaid Director. And so it's really sort of that background that brings me to applied for this position. I also serve on the Minnesota Prescription Affordability Board and the MNsure board, both of which are very focused on trying to get aspects of our healthcare more affordable for our residents. And so one thing that I hope to see from this task force is policies or changes that result in net less spending for individuals and families, not just cost savings within the system that are absorbed by the system or saved within the system, but that individuals actually experience lower spending out of their pockets in some way that we can measure.
Thank you. Olivia.
Hello, everyone. Olivia Brandt. I am a pharmacist by training. So my education in lack of access and affordability started early on when I was, on the front lines delivering patient care, and I was helping, a woman who was on 20 plus meds figure out which of those meds she could go without for the next month because she couldn't afford them all, right? So that was really disheartening. It felt like I was impacting one person at a time. But it was really hard to feel like you're making a difference. But you saw it day in and day out. I also, like Jamie, have family members who would come to me with questions, and not everybody has a pharmacist in their family. I'm still helping my grandma with her diabetes medications and which one and how to save money on those today. And she's 95. So it didn't feel fair that not everybody has access to a doctor or pharmacist in their family. Where I sit today is I consult. So I work with large and mid-market size self-insured employers on their benefits that they provide to their employees and members. And one thing that I've learned along the way, we don't all know how we get access to our drugs. How we pay for things is just very different than other countries. It's not like you can purchase drugs like we purchase office supplies. It just doesn't work that way. And because of that, part of my goal is education. I think a lot of people don't know how it gets from the person that makes the drug, the manufacturer, to your household. Nobody understands those economics. I also get to sit in my company, in my firm, I lead our innovation practice. So what that means is I get to hear from startups and we call them vendors and point solutions that are really trying to make a difference for healthcare across the nation. And we get to hear all these fun ideas and ways in which they're impacting healthcare overall. So I hope I bring that lens to this task force as well as just idea sharing goes. And then lastly, just advocating. I do think we're focused on cost savings, which is really, really important. But one thing we've been talking to employers lately is it also has to be an investment because you can't just curb costs along the way. There's no ROI to that. So if you really think about some areas we may want to invest more, so you're spending, but perhaps there's a longer term ROI to produce from that. That might be also an angle to think about rather just cost savings all the time. Thank you.
Thanks, Olivia.
Morning, everybody. Glad to be here with you all. My name is Philip Cryan. I use he, him pronouns. I'm one of the elected leaders of SEIU Healthcare Minnesota and Iowa. We're a union of over 50,000 healthcare workers in hospitals, clinics, nursing homes, and home care. So that's kind of the primary lens that I bring to this conversation is the healthcare workforce that I have the privilege of representing. And, our collective bargaining for those groups. The cost of healthcare, the rising cost of healthcare is one of the top issues every single time we go to the bargaining table. We represent lots of different groups ranging from literally no health insurance whatsoever through all kinds of terrible, unaffordable, hard to access coverage, all the way to the other end of the spectrum. Some of our members have the kind of healthcare that we all really ought to have and deserve, and people in other countries are accustomed to. And so we kind of see it from all of those different perspectives along the spectrum, and would really like to see this group be able to produce, as has already been said by some of the other members, some measurable, significant reductions in the cost of healthcare. Also, when I was in graduate school, I did some research a long time ago now that ended up being part of the kind of federal debate about the Affordable Care Act, and have been involved ever since then in state level policy related to the implementation of the ACA, Minnesota Care, Basic Health Plan, and a variety of other issues. So kind of bring that lens as well as the the workforce one. Glad to be with you all.
Hello, my name is Marie Dotseth. I am retired. I spent a long career though in health policy and a variety of public sector, private sector roles. 3 different roles at the Minnesota Department of Health. And the one I retired from was the Assistant Commissioner for the Health Systems Bureau, and so glad to see Carol doing that job now. It's not easy. I'm doing this because I'd really like to see us do something different this time around. I mean, we've taken so many swipes at this problem. Started taking swipes at this problem when I had dark brown hair. And now, partly because of healthcare costs, a lot of gray. So I'm also in a position individually now, being a retired person before Medicare eligibility, to get to go out into that big, beautiful individual marketplace. So it's personal. It's always personal for us. But I guess, the big question for me, and the one thing I hope to see us tackle, is how will we do this differently this time around? I don't think it's a matter just of understanding the data better. I think we need the data desperately. It's very helpful. It's necessary, but not sufficient. As a former colleague used to like to point out about different things. So we need the data, but I don't think it's a technical problem, if you will. I think that the problem we face in healthcare affordability, which I see differently than healthcare cost, which I see differently than healthcare value. I think those are all related concepts that we hopefully can come to some clarity on. So I hope we're able to make some progress. I hope we spend a good long time really pinning down what we see the problem to be, because I think the problem definition is going to be a big part of what the solution is that we come up with. So I'm happy to be here and hope to see us make some progress.
Good morning. My name is Adam Janiak. I'm from Cottage Grove. Like the rest of you, there's both professional and personal reasons why I'm here. I spend my days and my nights working for Education Minnesota and supporting over 80,000 members who are educators in the state, ranging from teachers to bus drivers to paraprofessionals and all school employees. What I see on a day-to-day basis, and I work in the negotiations department and I'm our point person for healthcare, and what I see on a day-to-day basis is not only individuals having to make tough choices about where they're going to get their insurance, or can they even have, is it a true benefit that's being offered because it's affordable or not, but also those decisions about what to do about their families and whether or not they can stay in the job. We have lots of folks who are saying we cannot continue down this path. Additionally, I'm talking with superintendents and others about the funding stresses that they face. So we actually have a shared problem. We don't agree on everything when we're talking about the work that we do. But when we talk with superintendents, this is a shared crisis. You'll see later on the amount of the state's budgets that are being eaten up by healthcare over time. School districts are seeing the same things. And when we talk about our priorities in the state and what we're trying to do as communities, we are eating away at those potential resources, not only for our educators, but for our students and what they're trying to do with their schools. So thinking about that professionally, it's all in line with what I do on a day-to-day basis. But also personally, I, like many of you, have not only those families and friends that have made those tough choices about what care can I get, but I also have those specific instances where I have family members who have gone into debt. Not only because they had to get the knee surgery, that wasn't a choice, but also because they had to miss the work that went along with it and then had to borrow to pay that back. And so thinking about how we have some folks who are out there that can not only access their healthcare, but then move forward with a solid framework in their job and their employment and their life and not go backwards, to those others that it'll take them 7 years to pay off that knee surgery, just hoping that nothing else happens. And that's not sustainable. That's not sustainable for our workers. And that's definitely not sustainable for those of us that have family members going through that and caring about that. So what I would love to see in this task force, and love that there's great history, and we have at Education Minnesota been fighting for years and years and years to do better. Actionable items that we can actually take steps forward, not get drowned in this. This is the one solution to the bringing your solutions forward, or this is the other solution. Like, what is the better end game? But how can we take those steps forward with multiple end games, or one big, if we can all agree on one end game in mind? But how can we take real steps forward to make change now?
Thank you, Adam.
Good morning, everyone. My name is Andrew Knox. I am a lobbyist for legal aid and healthcare specifically. That's my professional, I guess, reason for being here. I guess what got me into this is actually something personal. It was my wife. She was diagnosed with cancer, a rare appendix cancer that you couldn't get treatment except for through a surgery. We found out that surgery is going to cost us about $75,000 in order for us to have. I have insurance. My wife actually works for a hospital, so we thought we had great insurance, but also the insurance started getting denied. And then we had to have hard conversations with our families. My parents had to even offer to sell their home in order for us to have that surgery with my wife. What it turned out to be is the surgery was miscoded. It was miscoded multiple times. And after going through the process of finally getting it coded correctly and finally getting the insurance we needed to give her the surgery, I called my boss because at the time I was a consumer attorney. And I said, I want to do something about this because I think about all the people who aren't attorneys, who couldn't figure this out, who just decided, I'm not going to have the surgery, and unfortunately may have passed away because of it. So I don't want that happening to anyone ever again. And as a consumer, or as a new healthcare lobbyist, seeing this new bill that was passed and understanding there's going to be so many people who might now no longer be able to have insurance due to our Medicaid or Medicare, I'm worried again about more consumer debt, I'm worried about higher costs, and I'm worried about people even being able to get care. Not to mention, since they're not going to be going to doctors, they more than likely won't go until they have an emergency, which is also just going to cost the state more money as well. So I think this is an issue we need to tackle. I hope not only to have ideas, but to build relationships as well. As a healthcare lobbyist, I'd love to hear ideas, how to help. I just want to get into this fight as much as I can. So.
Good morning, everybody. I'm Phila Maroney, and I'm the Executive Director for the Patient Revolution, which is sort of misnamed. It should be called the Care Revolution, because one of the unique aspects of it is that we bring all healthcare stakeholders together at the table to talk about how we might respond to the current environment of healthcare, both from an affordability as well as a delivery standpoint, to ensure that everybody is getting access to to care. So I come at it not necessarily from an affordability standpoint, but from a position of what is the ideal care that people want. And so thinking about the word value shows up in a lot of the prep materials. And I think value often gets equated with money and affordability, but there's also the value and the quality and the meaningfulness of the care that people are receiving. And I hope that topic can stay on the table. I come at this after, I spent my career at the intersection of policy and healthcare delivery. I worked for U.S. Senator Dave Durnberger in the early 2000s and to support a different healthcare cost commission. So like Marie, we've been at this for a very long time, but I also have been inside healthcare, working for 15 years at Hennepin Healthcare as the Chief Experience Officer. So I've seen the intersection of policy, financial policy with challenges, people getting access to care. I also come from a family of clinicians, and so kind of my three-legged stool is a frustration knowing that in particular in Minnesota, we have unbelievable care here. We have unbelievable innovation and we have incredibly talented expert clinicians who want to care for Minnesotans. And there's a financial barrier between the people who need the care and the people who want to give the care. And I see their frustration every day, knowing that there are patients who are not able to make it to their clinics and their offices and their operating rooms because of affordability issues. So the reason I wanted to be part of this task force is, I shared, Alex, I'm very impatient about doing something different or building on, let's just say. I think Marie made the comment that the data is really important, and I haven't said hi to Stefan yet, but thank goodness we've got people like Stefan still on duty here, providing us with incredible data, and we should build on, but not redo the intellectual property that's already been generated by lots of people in this room, as well as others who are not here. Let's just move forward and consider some of even revisit some of the proposals from decades past that were probably good ideas then, and they're probably still good ideas. So I'm impatient and I'm eager, and I'm also very hopeful. And I hope that I think that the voice overhead is Jessica. It was really strikingly powerful, Jessica, to hear your personal stories. I'm sorry, Jamie, overhead. And I hope that we will continue to bring the voice of the patient and the family into this room via our own personal experiences, but also other voices, because it's an incredibly powerful and inspirational tool for us. Thank you.
Thank you. Good morning, everybody. I'm John Naylor. After 25 years of consulting, helping employers, I went to the health insurance side and spent 14 years on the health insurance side. And the last 2 years, I've been on the provider side. I'm actually helping rural hospitals survive and trying to figure out how we provide access to healthcare for rural Americans. So we're setting up clinically integrated networks on a statewide basis across the country because we need access to healthcare for everybody. And I think for this committee, I stepped into it because I've got a breadth of experience, but really I want to see some action to your patients. And I'm curious to see what we can actually impact. This is a very complex thing, healthcare, and affordability to whom. There's so many different ways to define this. I look forward to working with this group and say, okay, what can we actually impact and actually figure out a path to that change? Because a lot of people have talked about it and we need to get some action. So I, like you, am impatient. I want to see us do something. So look forward to sharing ideas with everybody and see what we can do.
Good morning. My name is Mike O'Brien. I have a background not dissimilar from John's. I'm retired at this point. I had a career. I worked for almost 30 years for an insurance carrier in a number of roles. And then I spent the last 15 years working for a national brokerage firm in the employee benefits world. And in that world, I got to see an awful lot of the challenges of a subset of purchasers. And we spend as consultants an awful lot of time helping them manage cost and manage risk, trying to invest in health, but not necessarily having a really good baseline of what we're trying to accomplish. When your success measures are against national trend or local trend, that doesn't necessarily feel all that successful. So, with that, I spend an awful lot of time in the nonprofit, working with nonprofits, really came to appreciate at a different level the challenges of access to healthcare, affordability of healthcare. And so with that, my goal or my desire to, as we walk through this process is to contribute in a meaningful way. But I'd like to see us focus on the aggregation of health cost, not the allocation. We tend to all have our own silo of, I'm an employer, I'm an individual, I'm a Medicare participant. And until we get our arms around what is the total cost of healthcare? What does access to healthcare do as it relates to impacting the cost? And quite frankly, where do the investments in health pay dividends in healthcare cost? Because, I think if we just try to tackle the cost of healthcare, it feels like whack-a-mole. And really, I'd like to see us create a baseline. And then as we work towards some, I would say meaningful recommendations that address the total cost. And so again, I'm going to say that a couple of times, because to me, it's really important that we, set our own personal agendas and experiences aside and say, what is the total cost and how can we impact the total cost? And whether it's our role or not, somebody should then tackle how to allocate that. Because today, as an employer representative, an awful lot of cost gets pushed to employers. And there's an awful lot of emotion around where the cost is getting pushed and not enough focus on what's driving the cost. And so I'm really excited to be here. So thank you for having me.
Good morning. My name is Bree Ostrom. I'm the Director of HR Operations and Total Rewards for a company called Vesco Water. We are based out of Chanhassen, Minnesota, but we acquire companies throughout the United States. So I see a lot of different health plans that we roll in, under ours. We acquire some companies that are smaller and can't afford benefits, so they don't offer them to their employees at all. I also have employers that we acquire that cover almost all of their healthcare costs. Right now, we're managing a 12% renewal on our healthcare plan for next year on a fully insured basis, and that's only because we had a rate cap guarantee from last year. I have other people in peer groups that are navigating 20 to 30% increases on their health plan. So right now we're in the process of moving to self-funded for next year so that we can try to, as an employer, manage those costs. We're looking at those innovation ideas, like a razor metrics and a coop, and how as an employer can we make sure we're trying to lower costs for our employees. We cover a good portion of our healthcare plan, but there is a portion that we pass on, and it's still a decent amount that gets passed on to the employee, and a big portion that we pay. I've also seen, the people that are getting ready to retire, but they aren't Medicare eligible yet, and navigating that. Do they come onto our COBRA or do they go to the individual market? What does that look like? And then I've also seen, the patients that are trying to get a prescription covered or a procedure done, and they're getting denial after denial, and it's after the second appeal that it finally gets approved. And I don't think that is the way that it should work. So I have both the employee perspective, helping them navigate that, but then also that employer perspective. How do we manage these costs? Because it's a big expense, a big line item in the budget every year. So I'm excited to see what we can come up with. I want to see some actionable things that we can actually implement and, take away from us.
Hi, everyone. Justin Stofron. I work at Minnesota Farmers Union. We're a grassroots general farm advocacy organization representing family farmers and ranchers across the state. And, farmers as independent business owners are sort of disproportionately impacted by, the high costs in the individual market. We also have a lot of members who, farmers' income can fluctuate a great deal. And so we have folks who have dealt with being eligible for public programs and then no longer eligible and then maybe eligible again, and sort of navigating that whiplash. And our members have long prioritized both affordability as well as access to healthcare in rural communities, which can be challenging. I think I also bring, we do a lot of our healthcare work, in addition to being able to bring sort of their perspectives and their voices. We do a lot of coalition work on healthcare, and so hope to be able to bring some of our other partners' voices that aren't on this task force to this work. My particular role at Farmers Union is I'm our anti-monopoly director, so I lead our sort of antitrust and competition policy work. And I think that feeds into sort of one of my hopes, in addition to agreeing with a lot of the other ones that have been shared here, but is to sort of bring that competition policy lens to these discussions, because we know consolidation can be a key driver of costs throughout our healthcare system. And so excited to be able to bring that perspective.
Hi, everyone. Good morning. My name is Laura Zabel. I'm the executive director of a nonprofit called Springboard for the Arts. Springboard is based here in Minnesota, both in St. Paul and in Fergus Falls, and we work statewide. Our work is really about supporting artists and creative workers to be able to make a living and a life here in Minnesota. And that includes a whole set of different kinds of resources and support programs. And a real through line in our work has been work around healthcare and healthcare navigation and affordability. So we have, over the last 20 years, run programs that help connect folks to community clinics and developed a network of community clinics. We've been a MNsure navigator. We've done all kinds of resource connection programs. And this still, even after all the changes of the last, 20 years, it's still probably the #1 barrier for folks to be able to make a living as a creative person and as a creative worker in this state and other states too. I think something that I'm particularly interested in bringing to the conversation is, Springboard works with about 20,000 artists every year here in Minnesota, and the vast majority of those folks are self-employed and gig workers, which is not specific to artists. That's a growing population in our community. And I think not only do those folks face huge affordability challenges, much like farmers, very volatile income and hard sometimes to document over the course of a year or longer, but the navigation challenges just compound the affordability piece. So my hope is to bring some of that lens to this work too, that whatever solutions we come up with or steps, not only do they need to impact affordability, but they also need to be accessible and easy for people to navigate and use, particularly people who don't have an employer or an HR director to go to get that help, who are kind of on their own trying to figure it out to take care of themselves and their families. I'm happy to be here.
Turn to Julie. It's going to facilitate. You want to say a little bit about your background?
Good morning, everyone. My name is Julie Sonier, and I am a senior fellow at Mathematica, which is a policy consulting firm that is based in Princeton, New Jersey. I live in St. Paul. I've been working on healthcare policy in Minnesota for the past 28 years. The way I remember that is the age of my oldest child. So my husband and I moved here because it's a great place to raise a family when our oldest was an infant. I'm so thrilled to be able to support the MDH and the task force with this work. Some of my favorite work to do is working with multi-stakeholder groups to understand data and trends and the intersection between that and sort of policy. So really thrilled to be able to do this. I worked for many years for MDH, including the health economics program. So really appreciative of the, Carol mentioned some of the things that make Minnesota really well positioned. I think another one of those is the really strong foundation and past investment in data collection and analysis and just really robust information that will be available to the task force to support the work. I have also served for a couple of years as director of the state employee group purchasing program. So bring that perspective as a purchaser as well. And for the 7 years before I joined Mathematica, I was the president and CEO of Minnesota Community Measurement, which is a nonprofit that again brings all the stakeholders to the table together to try to figure out, at least let's get on the same page about how to measure and improve healthcare quality. And also there's a cost component to that as well. And one of the things I really appreciate about what you all are saying is really the personal stories that you all bring to the table. And I have many of those in my family as well, thinking about challenges that people have experienced. So, relative with heart disease who didn't get her blood pressure checked because she couldn't afford the copay for the visit and those sorts of things. And you think about the long-term impacts that has on real people. So I really feel like it's important to keep grounding the work in thinking about real people and impacts on real people.
You're pleased to have Julie on our Mathematica team. And we have a couple of other Mathematica team members that are online today. And I also just want to call out, I wish that we could do full intros all the way around the room, because as I look around and as I look at the names online, we just have a lot of people who have been working on this issue. I think of, we have some representatives from, as well as online from our state legislature who have worked on this issue and worked on the center and creating the center. We have folks who have been researching this issue and looking at policy solutions from kind of the nonprofit and the academic side of things. We have other representatives from the Minnesota Department of Health that have been working on this. So I wish we could go around and do the full introduction, just because there's really a lot of expertise that's looking into this effort and so ready to support this effort. And I just also want to thank this group. I've just been making some notes on, some of the themes that I'm hearing and the representation that we have from rural Minnesota, from farmers and artists and gig workers and educators and healthcare workers. So even, within this group, we have a lot here. And we only have 15 seats, and it's also, we have 15 seats. So it's a big group in some ways. And we need those voices around the table. We need the people also online and folks sharing their personal stories, because I just really appreciate some of the personal stories you all are bringing. And I recognize there are many that can't be here, and we need to go out and find those. That is one of the jobs of the center. So thank you for your commitment and your time. Thanks, Julie, for sharing a little bit about your background, and we're pleased to have the Mathematica team. You'll be hearing more from them, since they've done a lot of work with other states and can bring that expertise. I'll just note in your packets, folks at the table, task force members, you have a little bit more on the members of the Mathematica team, so you'll be hearing more from them. We are doing great on time. I'm just looking at, I think we had a little slideshow thing, so I just want to make sure that we have those properly up. I'm going to say a little bit about, and you know what, actually, if Jessica, you're online, are you able to take control over the slides just so that you can go forward so that I can go back on things? Are you able to take control?
Yes, I just took control.
Took control. Excellent.
Please.
Okay. Are you able to go forward? I just want to test this.
Let me test.
Okay, it might just be easy enough for me to do
Okay,
it.
I'm not able to.
Okay, no worries. Hey, you can give back. I'm going to take back. Thanks, everybody. It just takes a village on these things. Okay. I'm going to say a little bit, we're about 10 minutes ahead, so that's great. We'll give ourselves back a little bit of time either at the end or in discussion, whatever this feels meaningful for this group. I'd like to just offer a little bit about what is the center, what is this group's opportunity, and why are we here? So you're going to hear more about what the impacts are of high healthcare costs on Minnesotans. You know a lot of these, but just to sort of frame why the center exists. The center was created with this belief that Minnesotans really should be able to go to the doctor, get really just even the most basic healthcare without dealing with the fear of bankruptcy and significant financial distress. And what we're seeing is in survey results, these are from the Alterum Consumer Health Access Survey, Healthcare Experience State Survey, and we'll see a little bit more of these data later. 3/4 of adults, 1 out of 3 to 4 adults in Minnesota are saying we're pretty concerned about being able to afford our healthcare. And the reason I think this is a big deal is because most adults in Minnesota are insured, like 95% of them. So like we shouldn't see that being quite so high if insurance actually works. So what's going on there? Almost half of Minnesota adults are reporting struggling to get access to healthcare due specifically to costs. So when asked, is it transportation, is it childcare, is it other things? It's cost for half of individuals. They're actually foregoing care. And importantly, when we compare the year-over-year cost per person of healthcare that we are spending in Minnesota, it's growing at a faster rate than the growth of wages. So just at a basic fundamental, can we afford it? This is one indicator that we cannot. So again, we know these stories, so I just wanted to sort of ground us in some common understanding of how do we define the problems here, and we're going to get back to a lot of these with our health economics program. So that's why the center was created. The center was created to do a couple of different things. One is to look at those cost drivers. So again, I heard some common themes of data are essential, but maybe not sufficient. And I think that's a core sort of philosophy that I'm thinking about, and we're working together with Minnesota Department of Health to make sure that we can get really granular. We have a really strong data and analytics team in Minnesota, I would say compared to other states. I think we're kind of ahead of the game in that regard. And so that's part of the center's job, is to really look at those cost drivers, what is causing the year-over-year growth, and look at policy solutions and develop policy solutions that can make real change at the systems level. That's something else that I heard from this group. What can we do at the systems level to ensure we're putting dollars actually back into the pockets of consumers? So it's not just about shifting costs around, but can we look at policies and solutions that actually result in real affordability impacts? And the third thing that the center is called upon to do, and I think that's where we'll really spend time together, is on convening. That is, the center is called upon to bring together task forces, both formal like this one, as well as the other advisory task force that will come together later this year, the Payer and Provider Advisory Task Force, to inform the work of the center. And so that's where we'll spend some time talking about sort of your authority and deliverables. In addition to these formal task forces, the center is called upon to do stakeholder engagement writ large. And so that's where the people around the side of the room today, and the people that are online and others who are sort of interested in this issue can weigh in. And so more to come on public hearings and story sharing. That's a really important part of the center as well. And I think something that when we think about data are essential but not sufficient, that's really the other part that I think is really important for the center and for this group to be helping us bring to the table. The task force has a charter that is available online. You'll have seen it, and we're going to come back to that charter and spend some more time with it. But just in terms of what to expect and what your authority is, what's the opportunity, I wanted to highlight a couple of items. One is that the recommendations that this group makes go to the center, they go to the Minnesota Department of Health, and they go to the commissioner. But the recommendations that this group will make should and can encompass a broader set of actors than the center or the Minnesota Department of Health. Again, we're looking at the full system. We have a full ecosystem of potential actors, employers here represented. We have payers and providers, obviously. We have a different part of state government that we can be thinking about influencing. And so I just want this group to be thinking about that in terms of your influence and who you want to be thinking about in policy change. Recommendations are not binding policy solutions. They go to the center, and the center's job is to synthesize those alongside the Payer and Provider Advisory Task Force inputs in order to make recommendations for policy and strategy. We're going to aim for consensus with this group. And what I mean by that is we're not going to be using formal voting structures. We may use sort of data collection and levels of support, inputs from you all. Can you live with this? Do you strongly support? You need more time to think about it, that kind of inputs. We'll take surveys, that sort of thing, to collect additional inputs. I just wanted to give you a sense of that's sort of the tenor we're looking for. We're looking for consensus. We also we don't believe that consensus will always happen, and that is okay, especially as we think about the Payer and Provider Advisory Task Force. Their voice is super important, and they're just going to have a really different perspective on these issues and may ask different questions. They may look for different policy recommendations, and that's on purpose by design. We've really thought about that looking at other states. And that's why this group is really, we're holding space for you all to kind of come together first to provide some guidance. They're open to the public. All of the meeting materials that will be available online. And of course, all of the sort of discussions that we have here are open to the public. And importantly, this group is coming together for 2 years. But as Carol mentioned at the outset of our discussion, the center is created in perpetuity. It's the first time Minnesota has done this. And so I just want this group to begin thinking about what that means in terms of recommendations. So there may be sort of a 2-year time horizon. There may be really sort of urgent issues. And I don't love the phrase low hanging fruit, but that may be the best sort of way to describe that. And there's also sort of the 5-year and 10-year horizon that this group will want to be thinking about and recommending, knowing that this group will only sort of be together for 2 years. I know that this group is, I hope this is generating questions. And what I want you to do is sort of jot those down. We're going to take a break in a couple of minutes. We can talk at the break. We can also talk in our discussion at the end of the day to bring some of that back up. But what I'm expecting is that this this first meeting is an opportunity for us to test out what else do we need to know? What else does this group need to know in order to work together and have a really clear understanding of what you're doing? To that end, what are you doing? So here's the roadmap. This is what I'm calling the roadmap. And it is a very draft, maybe a straw person illustration of what it could look like for this group to come to some recommendations. The reason I say it's a straw man is because you may not want to wait to go from September of 2025, where you're understanding the charge, we're figuring out the charter. You don't want to wait until spring of 2027 to be making recommendations and developing policy options, right? So that's why I say this is a straw man, and it's an illustration of what it could look like to kind of move through looking at the landscape, narrowing and prioritizing, and then recommending policy options. But there may be an opportunity for you to kind of use this framework to think about, okay, first we're going to review the landscape, which we will begin today, this after the break. Select a couple of areas or domains that you want to drill down deeper on, and then you can kind of go through this process of refinement and collecting input. So I just share this as, again, something to start thinking about. I'm going to ask you again over the coming month and in the next meeting to have a deeper conversation about this, about how you all want to be working together, and also just sharing more about what we at the center would believe is really helpful for us. I want to just highlight in the gray what's this group is making policy recommendations, but I don't want you to be limited to not remember, to policies or sort of legislation, rulemaking, but instead we also need, as you all share personal stories, we need those stories, we need those other stakeholder voices at the table. And this group brings a really important network. And so to the extent that you all can be informing the research, both qualitative and quantitative, that we are doing at the Center for Healthcare Affordability and the stakeholder engagement that we're doing, we're looking to you all to help influence that as well. With that, we are I think, a little bit early on time, so that's great. And I wanted to just pause and since we do have time, I'll open up for a couple questions if people want to begin thinking about both these issues of sort of authority and what the group's opportunities are, and initial sort of questions coming up on the roadmap, and then we'll take a break after that. That's my first question or comment.
I have a question, Alex. So I have like 10 ideas about other resources and organizations and such that we might want to hear from. So do you want those recommendations in writing after the meeting? Like, should we send you our ideas via email? Should we talk about it as a group? How do you want to proceed with that? Maybe there's no rule for that, but what's your preferred
way of sharing input? I think it can be both, and whatever you all prefer as well. And there's going to be sort of invited times for those as well.
Okay.
Your question also makes me think about the fact that this group is going to need to go through sort of an ambiguous period, and we will tell me about it. And we will need to sort of pass through that abstract in order to get to a place where we're talking about policy. And so the reason I'm kind of thinking about it, that in terms of who's going to come to the table, gosh, the list is long, right? So like, how do we narrow that? There may be sort of a period where we need to have everything on the table before we're able to say sort of who's coming to, who's going to come to speak to us and that sort of thing. I'm not saying that to not send those ideas, but I just want to set that expectation that send them all, right? And we'll have to sort of do some work together to think about which is gonna happen first and where do we want to devote time. Does that help?
Yeah, it just, sorry, it's one quick follow on, which is, I think it's kind of, it's a two-part opportunity. One is to hear directly from some organizations or some experts, and then the other is just to have a meeting. So as you and I talked about before, there's a Healthcare Cost Commission report floating out there in the cyber world somewhere from 2004 that we can't find, but it might be useful for people to just look at, not only to reflect on history, but some reports from current work that people are doing
Thank you.
outside of this.
You said that you want to aim for a consensus as soon as possible. If we don't have it, does that mean that recommendation is not moving forward, or what role will that have if there is no consensus?
A good question, and I don't have a really clear answer for you today. And I think I'd love to take that back as sort of, this is an area where we need more clarity. If that is something that this group really needs to say, is this a yes, is this a no? You know, if that is helpful for this group, we can certainly provide it. I think my style is to be a bit more, like, we're all here together, it's just us, let's figure it out. But I hear your question, and if that's something that's gonna kind of limit the group, if we don't have that kind of, yes, it's going forward or it's not, then we should provide it, because our job is to make this group successful. Others have sort of questions about that or want to add to that?
I think it's worth continuing to explore. I kind of have a working hypothesis that our problem in coming up with kind of actionable solutions that gain traction is not one of like not understanding the problem, but we're kind of in this homeostasis with these competing interests that won't let us politically move off of a status quo.
Yep.
I mean, we're kind of held in place in the system that we've got right now because of the political forces. And I mean that in, capital P and small p. And so it does kind of raise the question, if we have to come to consensus, is that gonna move us in any particular direction or just kind of hold us where we are? And I don't have an answer to that right now, because I totally appreciate how that we need to work on consensus, but it's not because you all smart people can't see what the problem is here. It's because that somebody, I mean, Matt mentioned cost shifting. I think Mike did in some way. A lot of people mentioned, this isn't just about shifting a cost from one sector to the other, but somebody's cost is somebody's income. And that's just the reality of where we live in this world. So I don't know what that says for consensus. I'm just admiring that problem also.
We just appreciate, that, Maria, and I want to invite others to chime in as well, but something that's coming to mind for me is something that I find helpful in these kinds of groups is to have some guiding principles that can say, this is important problem, we need to put it to the side because otherwise we're not going to go anywhere. So I just am wondering if that would be a one way of sort of moving this group ahead, but taking these points as this is a question, how are we going to not get stuck? Because one of the problems we're facing is that we're in a kind of status quo with not a lot of urgency. So how do we get over that hump? I appreciate the point. Why don't we go to break? Take 10 minutes. We'll come back and do you mind if we come back just 5 minutes early? Again, I want to just give you a little time on the other end. And so we'll come at 10:25 back together. Thank you. Yeah, that was well said.
How's your knee? Also, Mike, that's
Jessica, just wanted to see if you can hear us. And let me know if how this sounds with this mic on.
We can hear you and it sounds perfectly clear.
Okay, we have a request for a mic, so. Thanks, everybody. We're gonna get back together and I just want to invite you to please stand up, get food. There's a lot of food. Do that and feel free to use the bathrooms right out back this way. I also want to introduce just one person that we didn't really get to go around and introduce, and that's Diane Rydrick, the division director at the Minnesota Department of Health for Health Policy, and has been doing this work for a long time. And I just wanted to make sure to give her a moment to just introduce herself. And then we're going to turn over and I'm going to ask Stefan Gildermeister, our state health economist, to introduce himself because he's also been doing this work for a long time. So really important people for this group.
I'll keep it brief. I'm Diane Rydrick. I'm the director of the Health Policy Division at MDH. And as Alex noted and as others have called out along the way, this center is a long time coming, really building on analytic work, policy work, and policy change leadership that has been happening in the department and with a wide range of stakeholders for years. We were thrilled when this language passed. And really put the stake in the ground that this is something we as a state need to commit to for the long term, not as a time limited group, not as a one-time conversation, but as something we are committing to ongoing. And I'm pleased to see we've got our chief legislative champion and author for this in the audience, even if she might not call attention to it herself, but she's back there. Representative Breyer. But I just want to acknowledge everyone who's here today. I really appreciated hearing the perspectives around the table, especially that so many of you expressed impatience for change and a desire to just call out the politics for what they are and urge us to try and get past that, not in a Pollyanna way that we can snap our fingers and wish away politics and political dynamics and power dynamics and financial dynamics, but just acknowledging that challenge at the outset and noting that we are motivated to get past that and not admire the problem for another few decades and not just admire the data for another few decades. I love hearing that in a first meeting of a task force because I think that really sets us off on the right foot with the right energy. So thank you all for being here today. To the back.
Thank you, Diane. And Stefan, I'm just about to turn to you. Just a couple of other things. One is, this is kind of weird, but just for the protection of state tax dollars and people's tax dollars, people in the audience, we urge you to go get coffee and tea right outside the room. That we ordered so that enough food and coffee would be here for the task force members. So just wanted you to know that there's some yummy things right outside. And one other thing was that I didn't get to mention that we have two task force members that I knew would not be here today. They're not just like empty seats. Lois and Sheila Cascaden and Lois Stevens, both sitting in people bringing health policy expertise seats, bringing lots of other expertise and personal experiences as well. But we will ask them to introduce themselves next time. We're really pleased to have them. They are out of the country, so just good to be here. And then last thing I'll say is we have Care 11 here. Sorry, Jessica, I'm just going to call to you. If you have questions about that, I do think we might be on TV tonight. So just if you are concerned about that or wanted to talk with her, please do so. And she'll be pleased to answer questions. Thanks, Jessica. Stefan Gildermeister, really pleased to have our health economics program here today. And he'll share more about what that is, but just think of this group as really the first of many conversations about the data and a capacity for this group to sort of call upon to ask questions and bring additional analysis, insight for this group. So as you're listening today and you have the slides, I really, and you'll probably give an additional framing, but I really want this group to be thinking about what is missing, what resonates with you, where do you really want to say, this is what we mean by sort of the progress we need to achieve. And don't necessarily go straight to the solutions. That's what I kind of heard before, that we will get there and we will feel that impatience. And I just want to recognize that first, let's talk about the problem at hand. So that's why we're doing this first. John, thank you.
Thanks, Alex. I think my job is to lay the groundwork for your ongoing discussions to establish a set of facts, but I have to admit, in preparing this, I've been a bit conflicted. On the one hand, we have a lot of information to share with you. On the other hand, Maria, here what you are saying is kind of know the problem and we understand many of the challenges. Should we talk that much about the data and the problem? But you know, loving data as I do, I will still embrace that part. Also, I'm glad to hear we're ahead of the time, Alex. 10 minutes, can I take them? Anyway, my role is to whet your appetite, so I can't tell you everything that I wish I could, but I'll try to keep it to 10 to 20 minutes. By way of background, and can we move to the next slide? Do I do that? I can do that.
I think Jessica has the slides and there's just a little bit of a delay, so thanks for.
Got it. So I'll talk a little bit about where I'm from, so to speak. I'll provide you some data and I'll close off with some work underway, and then I hope you have some really difficult questions for me within the time that we have available. Next slide, please. So again, I'm Stefan Gildemeister. I'm the state health economist, and I direct the health economics program. Next slide, please. And I say this so that you know that although I'm standing here, there's a group of really smart public employees who do this work and have helped bring evidence to the table today and every day, really. But what's the health economics program? We are and have been for a long time a health policy and research shop where our role is to monitor the healthcare marketplace, to help the public and policymakers understand the factors that influence healthcare cost, quality, access, and as healthcare intersects with many, many more issues, our portfolio has been expanding too. Our role ultimately is to provide objective technical assistance as policymakers weigh health policy decisions. Our work is data-driven, and we tend to work with data and not just in the back rooms of our offices, but really to present it to you all in presentations, in testimony, through issue briefs and reports, and hopefully simplify sort of the complexity of what is healthcare. You know, I've done this work for way too long, but I'm really excited seeing you here, seeing the center materialize, because I expect and have been really excited to hear you talk about how you're wishing to really help us make progress, help us provide strategy and power to policymaking decisions. And what excites me about that is that it's an opportunity to help shape our work analytically. So that the right information becomes available, that it's compelling to decision makers, that we understand the trade-offs of making decisions or not making decisions. Next slide, please. As I said, our work is data-driven, and I'm flashing here for you a slide that demonstrates the prisms through which we look at healthcare, the experience of individuals, employers, governments, not for us to dig in, but to recognize, I think, as Julie was saying, that the state has made investments in analysis and data resources. And that's pretty unique in the national context, but also to acknowledge that there are some considerable blind spots that we have, and also that sometimes data only gets us that far. Your personal perspectives that you've talked about in your introductions are really as important sometimes as strong data and a strong analytic foundation. Next slide, please. So I want to start up, and maybe one more. I want to start up at a high level and sort of peel the onion from the outside, so to speak. So we spent a voluminous amount on healthcare in the US and in Minnesota. And what we're showing on this slide that in 2023, it's almost $70 billion. My colleague, Michelle, has looked up some context numbers for you. And I don't know which resonates, but 70 billion is about 3 times the annual federal budget for NASA. So we are preparing to fly to Mars, I suppose, or Venus, or you pick the planet every year through our healthcare spending. But not only do we spend voluminous amount of healthcare, of our economic resources on healthcare, we also, healthcare spending grows persistently and generally at a high rate of growth relative to other economic measures. Next slide, please. So this is looking to tell a story by comparing healthcare spending growth. This is cumulative over time compared to growth in the gross domestic product. Think of it as the economy per person wages and national inflation. And clearly healthcare spending outpaces all of these metrics, creating real concern, I think, for the sustainability. And we talk later maybe about what's affordable. I think as a society, as a community, we can decide to spend more on healthcare and find it worthwhile. But to an extent, it's also a question of sustainability. And I think this slide indicates that if the historical trend continues, sustainability is a real question. Somebody asked me in the break, Sheila asked me in the break, why did you start with 2013? And I was bragging to say, I can go back to the late 1990s. I'm a simple man. We just looked at 10 years, but if you're interested, we can look farther back and sort of cut and slice the data by looking at recessions, by looking at periods of price growth that differed for reasons that sometimes we understand and sometimes we don't. I think I want to go to the next slide, please. So not only is healthcare spending in Minnesota and in the nation substantial, voluminous, it also represents an economic commitment. And here we're looking at the portion of the economy devoted to healthcare spending. And without going into too many details here, I think what I want to highlight is healthcare spending accounts for a substantial amount of the state economy, and it represents a growing amount. We can cut and slice this data in different ways to make that point, but essentially, a portion of the economy in Minnesota devoted to healthcare is growing faster than the overall budget. And again, that raises questions of sustainability or of choice, decision. Do we want that? Do we wish to spend more on healthcare instead of other priorities in the state? For me, this slide speaks to that. I want to recognize that ratios always reflect a numerator and a denominator, what's above the line, what's below it. So to an extent, the fraction of the economy could be driven by economic trends, or it could be driven by healthcare spending trends. Haven't really decomposed it, can do it for this slide. or for this presentation. But the main point is we're talking about really big numbers. And maybe to give you a flavor, if healthcare spending in 2023 had been only, in air quotes, at the level of 2013, it would have been a difference of $4.5 billion available for healthcare, for investment, for spending on other priorities. In rural Minnesota, for education, you name it. So these are important and substantial numbers, I think, that we're talking about. Next slide, please. And soon, one more slide, but I want to transition here to the rest of the presentation by sort of acknowledging that, yes, the healthcare spending that we're talking about here, and many of you have seen that in your work, and many of you have seen it in your lives, it has afforded us the adoption or the development of life-saving, high-tech treatments and access to real phenomenal discoveries in drug therapies that save lives, that extend lives, that think about sickle cell, that turns somebody from living with pain every day, always, to living a more normal life. But nevertheless, and I think maybe Alex, you've said that, it is, we have to think about that in the context of who can afford it, and at what cost, what are the trade-offs. So for the rest of the presentation, I want to look at the interaction of healthcare spending with individual experiences, lifting that from what you've said earlier to the personal level to more of a system, a population, a people level, employers and governments. Next slide, please. Healthcare spending at an individual level is the single largest expense for Minnesota households. I'm not going to say much more about that. Just let that sink in and ask yourself what that means for people and what it means for the choices that we make. Treating disease, seeing a doctor, getting vaccinations, yes, seeking care for complex chronic diseases, orthopedic procedures. It is on average the single largest household expense. What does it look like at a personal level? Please, next slide. People in Minnesota have employer coverage. Those who don't have employer coverage have individual coverage. I haven't analyzed these numbers, they change every year. So I'm going to look at the slide deck here. But for people who have employer coverage, on average, individuals pay for family coverage $6,000 per year in premiums. They're accountable for another $4,000 in deductibles. And employers, because they have to invest in employment, because they have to maintain their labor force, because it's sort of a social contract, pay on average $19,000 in 2023 towards health coverage. So this is, if you look at it, this is the cost of a car. And if you've looked at these data through other states, more and more will all put in little cars on the slide deck to demonstrate what we're buying every year. If you have individual health insurance coverage, you're lucky, I think, to have access to coverage through the ACA, the Affordable Care Act at the individual level. There were times when that was much, much more difficult and very expensive, but even coverage through MNsure with access to premium subsidies still means a single person. So Marie, you were reflecting on that. You're retired. You're not ready for Medicare. Um, Based on your income here, we have an example of a 50-year-old, which is about your age, the household income of $70,000. She's accountable for about $6,000 to $7,000 spending on premiums, another $4,000 on deductibles, and with an out-of-pocket max of $8,700. So spending up to that level before insurance coverage fully bears the cost of healthcare needs. So this is just at a personal level, a ton of money that individuals pay either directly through premiums or are accountable for paying at the point of service. Let's go to the next slide. How are we doing with time? Good, excellent. So healthcare is complex, healthcare is expensive. Many people experience it. That's a little bit of a shell shock. I got a bill. There's stuff on there. I don't understand it. I know I have to pay a lot. I didn't expect that. I didn't have the resources or expected to pay the resources at the beginning of the year. That sort of creates anxiety for the next policy year. And that creates stress, yes, but it also creates worry about cost. And when we ask Minnesotans through surveys how they're affected by it, by that burden, how they think about it, we hear that about 1 out of 5 in 2023 say they decided, 1 out of 5 Minnesotans decided not to seek care or chose to delay needed health care because of these concerns about healthcare. Maybe those who are not as good as they would have anticipated, but the worry, the stress, the expectation of burden, the concern about medical debt is baked into how Minnesotans think about healthcare. And of course, I don't know if we should feel good about only 20% of people with employer coverage are worried about cost of care, but for the uninsured, of course, the worry, the concern is much, much more significant. More than half say they have delayed care when they thought they needed necessary care. And we're talking here not about luxury healthcare consumption. This is access to a primary care doctor. These are access to prescription drugs that the doctor thought they should have, access to mental health services, access to dental services. We ask individuals for each of those components and then roll it up. Let's go to the next slide. And in some ways, maybe more worrisome, we think of healthcare on the one hand as preventive, on the other hand as treating acute or chronic conditions. And what this, the bars on the left show us, the second bar on the left shows us, is that people with chronic disease, the people for whom the healthcare exists, about a third say they worry about healthcare costs and have delayed healthcare because of the cost. Maybe stretch out their insulin, maybe not have cognitive tests, you name it. So it's really troubling and worrying. And I think as we hear more from people in communities across the state, more and more these stories will come to the fore. Next slide, please. And I'll skip over this. I'll let you look at it. But this is sort of an extension of the notion that healthcare cost represents burden, and it spreads about individuals. And when we ask them about it, it's really unambiguous. So as we think about confidence, the feeling that insurance protects you against high healthcare costs, it's not great. Moving on to employers and government. So most employers, next slide please, or 2 slides. Most Minnesotans obtain coverage through the employer, about 56% in 2023. And employers, therefore, are the agents that every year, in the face of healthcare costs, have to make decisions around who receives coverage, at what level of benefits, how much in spending to bring to the table versus to pass on to their employees, and how much risk to retain. I think one of you spoke about moving to a self-insured arrangement. Sort of the choice there is to sort of say, this, I, I take the risk of managing uh, the healthcare risk of my population rather than let the health insurance company manage it. Consequential decisions for businesses. These are, from what we hear, these are thankless tasks made really more difficult by rising costs, because you talk to your employees and tell them that what's happening in the school district next year or uh, at the manufacturing floor means that there's a trade-off between wages and compensation. And that's what this graph represents, the growth in employer contribution to premiums outpaces what employers on average pay in compensation. So employers face that trade-off. It affects their competitiveness in terms of their labor force, and it affects their relationship with employees. I don't know how many of you track this really directly, but the National Association of Healthcare Purchaser Coalitions that employers and their decision to purchase benefits and how to design those benefits came out with a survey a few days ago, and I'll provide the link to it. There are some choice quotes in there on the sharp hikes in healthcare spending that employers expect worth the read, really. I think the Wall Street Journal quoted one of the employers saying, or one of the researchers saying, the reaction of employers really ranged between being upset, being shocked, being freaked out, being resigned. And I know you know that, I know you experienced that, but that's the foundation on which I think you will have really important, helpful discussions. Government, moving to the next slide, is of course another important source of health insurance coverage in the US and Minnesota healthcare market. Government provides coverage directly. Government subsidizes insurance coverage. And government, like employers and like individuals, sort of has to make decisions about, together with the legislature, about how to design benefit, how to make trade-offs between healthcare spending and other policy priorities. And what this slide represents is, I guess, a little bit of an outcome of those tensions. What the graph shows is the overall budget, how it's increased over time, and the portion at light green that is devoted to healthcare services, whether it's coverage, whether it's administration, whether it's accountability, whether it's subsidy through reinsuring the individual market, for example. And again, we can dig into the data. I would be thrilled to do it, but what you're seeing is the budget is growing. Healthcare spending as a portion of the overall budget is growing faster than the overall budget. Again, it's a question about trade-offs, policy choices, and sustainability. Much more to say about it, but I think I'll skip here and stay here and maybe move a little bit to a wrap up here. And Alex, I know you appreciate that because you want to move on. Here's the next slide, please. So clearly, for today, for the high level at which I think it makes sense to stay. In the US and in Minnesota, we spend a substantial amount on healthcare. And as this graph shows, we're looking here across developing countries in the nation. We spend more than every other single nation by some magnitude. As I started out, as I meant to start out, acknowledging the higher spending doesn't seem to come with longer life expectancy, lower levels of chronic disease, the opposite. Unsure what the relationship there is between spending and healthcare outcomes, but it's not working in our favor. The question that one might say or might ask is, so we're spending so much on healthcare, what then should be the right amount be? What's the target that we're aiming for? And unfortunately, it's not that easy because there isn't really a right amount. The right amount for a society, for a community, is a social agreement and is a process of acknowledging trade-offs and making decisions. And I think that's what you're here for. And I'm so very excited about it. There seems to be a clear agreement in the nation, in the federal government, across states, among observers, this goal is not sustainable, and that at an individual level, we have really grave concerns about the place that we're at. And a lot of thinking has been happening and continues to be happening. And I know we will talk about sort of what is out there at some later point. I want to close by flagging for you some of the work team that I lead that may be of interest in your discussions to come. Next slide. And these represent the kind of studies that I mentioned earlier, thinking about the system, thinking about access, quality, cost. We are about to send the legislature a report that provides recommendation on really thinking about the needed provider capacity in the state. Clearly, we spend more on hospitals. We spend at the same time as we're losing obese services in rural Minnesota. What could a best system look like? How do we finance it? A recommendation for a study is forthcoming. We are clearly spending a lot on the system, a lot of middle men and women in the system, creating accountability, supporting employers, lobbying patients or providers. All of that represents administrative spending. We're looking at the data and at the productivity of that spending. We're asking ourselves again, to what extent are we delivering care that really is low value and represents a poor alignment between the financial incentives that we send and the values that we have in delivering and obtaining important, valuable, necessary evidence-based care. Working on a really big study on a counterfactual, what a single payer system looked like in terms of cost, in terms of access, in terms of service delivery. A big study. Ask me about it in the future. We are implementing an initiative recognizing that the healthcare market, competition, the financial and economic interests in the delivery system drive healthcare spending growth, and therefore is a factor that we should pay attention to. We're together with the Attorney General's office in an initiative where we look at consolidation, we review healthcare transaction, where we ask, is what is happening in the public interest? We work on a new initiative to understand some dynamics in the prescription drug market and partner with a PDAP in some ways. And of course, together with the center, work on taking a step back, looking at very detailed healthcare system data to disentangle healthcare spending and ask ourselves, what are the drivers? Not, oh, hospital spending is high and growing a lot, but what is it within hospital spending? What is it within long-term care? What is it in terms of prescription drug spending? And I think when that work comes forward in sometime in 2026, I'm really excited to talk to you about it. But with that, I'm at the end of my time today. Happy to answer questions, sit down, or stay here. I can sit down, signal.
Sit at the table, we forget. Thank you. Thank you, Stefan. And I'm going to do something real quick on the audio front. Oops. Was any difficulty? I told it was helpful for people in the room, and it sounded like maybe there was a little bit of feedback, but I think folks can hear. One thing I wanted to just highlight just on that previous slide and is that bottom data point, bottom bullet point, which is the dashboards looking into cost drivers. This is a best practice from other states that we have been looking to. I feel lucky because I came on to this role in January, and Minnesota Department of Health has been building these things, or has been really thinking about the structures that we need to make this center successful for a long time before me. So that's one of those things that I'm excited that this group will be looking to amongst the others that were listed there. But I just wanted to call out those cost driver dashboards as being a place where you all will be able to ask, what is it within these different service areas? What is it within different geographies, different markets? Is it price? Is it utilization? We probably have some hypotheses about that, but we'll be able to see at a more granular level than we have before using our all payer claims database. And that's exciting, and it's sort of best practice. So I just wanted to highlight that as an asset for this group. So thank you, Stefan. And wanted to now invite Julie to begin our discussion. We have a little under an hour, and then we'll think more about some themes that we're hearing.
Excellent. Well, thank you, Alex. I will note that they are hearing an echo online and just want to check in with Jessica to see if that's still the case. And if any of us are, like, I'm logged into the Teams meeting, but if you are, make sure that your computer is muted so that we're not causing any feedback. Jessica, are you still hearing the echo?
No, Julie, it sounds perfectly clear.
Oh, great. Thank you. So, we've done a lot of talking this morning and a lot of sort of talking at you, but now it is time for you to talk. If you could advance the slide, Jessica, there is kind of a set of questions that we wanted to, did you want to go through these?
Thank you, Jessica. If you can move actually 2 more slides, there are a couple of just stories that give a bit of a human face to some of the data that I think Stefan did a nice job of just illustrating that there are people behind every one of these numbers. People in this room have shared some really important stories. So you know a lot of these. I won't spend time with them here. If you can skip over these and we'll dive right into discussion.
Great. So now it's time for you to talk. This is our first meeting, and so we really want to learn more about where you all would like to dig in. So kind of the questions that we have teed up for you about, what resonated for you in the data that Stefan presented, what surprised you maybe, what do you want to learn more about, and maybe like, is there something that's missing that wasn't there, that is something, so you don't just need to stick to what we presented today, but think about, what did you not hear about that you think is important for this group to tackle. So we can get started. So if it's okay with you all, I will do this just because I think it's nice to have it just be very discussion-like, and I'm not going up there to lecture you, but I can if we need to for audio quality or anything like that. I think let's just start as conversational and throw out your comments. If we get to a place where like there's multiple people that want to talk, what I would suggest that I've seen work in the past is if you take your name card and maybe just like turn it on end to indicate like, yep, I want to be next, or I'm having trouble jumping into the conversation. That will help us keep track and make sure that people get a chance to talk. Jamie, since you are online, I also wanted to just invite you to jump in at any point, and even possibly to get us started if you have something that you feel like you want to say from the outset.
I'm still processing everything. I don't necessarily have any questions. It's just staggering to look at some of the numbers and see some of those statistics and percentages, but no, I'm sorry, I don't really have anything valuable to add right now.
Great, well, feel free to jump in, or you can also like raise your hand and we'll be able to see that, and I will make sure that you get a chance to jump into the discussion. So who wants to kind of start us off with some of the answers to, like, you know, what really resonated for you or surprised you or was missing in the data that you've seen already? Sheila.
I have two unrelated, well, they're all related. But my first one is something I mentioned to Stefan and you, Julie, at the break, which was I was surprised by slide 19, which shows the estimates of healthcare spending over time and then the annual growth rate. And what surprised me was the variation in growth. And I'd be very interested in, Stefan, I won't make you go back too much farther, but even just understanding in the last 10 years, what were the drivers of that variation? You know, it ranges anywhere from 7.6% to 2.3%. I mean, 2.3% sounds pretty good. So what happened that year that allowed us to be in that range? And if I may, you want to talk about it, or just, are we just throwing out questions?
It's sort of both, or comments. It doesn't have to be a question. So it just could be, you know, something that sparked for you with the information that was presented. And I'm assuming, and we're not going to put Stefan on the spot to like have instant answers to these questions today, but we will kind of keep a list of what people are interested in and kind of summarize, and that will give us, I think, some really good initial input for where to kind of dig in and like get what to prepare for the next meeting.
Can I throw in one thing? I've had a minute to just think for a sec. So if we scroll back to the slide, I'm sorry, I'm looking at it on my other screen. I'm scrolling back to the slide with the personal accounts. I skipped seeing my primary care because I couldn't afford the copay. Long story short, they ended up in the hospital for a week with sepsis. I'm wondering, like, how would we capture what the initial cost for like the preventative care or what that ER visit would have been prior to it getting to that point where you need to be in the hospital for a week, compared to like the cost of being in the hospital for a week? Would it have been, I couldn't afford my, say, $50 copay or prepay, but it was a, I don't know, $37,000 week-long hospital stay. And then what does that mean for us, like on the policy and budget end?
Yeah, really good question. Andrew, in memory.
I had two questions. One, you said in your presentation that the cost of healthcare is growing quicker than our budget is for healthcare. How long before it becomes completely unsustainable with this type of growth? And my second question is, I also, slide 32 that looks at the United States versus these other countries. Like, one, what are some of the differences with these other countries? Is it, do they have a private market or all government-based? And us having a private market, how much of that drives the cost up? Our spending.
Should I give it a try? Sure. And tell me if you're not hearing me well. Unlike Maria, I'm not a projector, a good projector. So the question of sustainability, you know, is really a tough one. You could argue it's really difficult to sustain this level of spending where we are right now. I mean, what we have done over time as a community, as a society, is devoted more of the budget towards healthcare. And in many ways, that has been about healthcare access, about affordability. So it's a choice to sort of say, we have tax revenue, putting it here, not here. I don't know that it is, that I am the person to know at what point we're sort of crossing a level that no longer works. But over time, I mean, folks have been saying, employers have been saying, we've reached a limit at which we can add a greater portion of the healthcare cost growth to consumers. So what do employers do? They charge a premium. They say to an employee, you have to pay a premium. And then to get a set of benefits, you have to pay a deductible, you have to pay some cost sharing, and those are factors that can vary. And they have varied. The employee share has been growing faster, creating greater concerns. And at the same time, the benefits might have shrunk. The networks have condensed. The point at which health insurance no longer meaningfully represents sufficient access to care, I think is an open question. But as you've seen in some of the data, and as you've seen in some of the individual stories, for many people, we've crossed that line before. So I'm sorry that I don't have a really clear answer. Andrew, to your other question about other countries, that too is complex, and I'll start by saying other countries regulate the price of healthcare. Other countries have wait lists for surgeries. Other countries have, when you go in a hospital, you're not confusing it with a hotel. It looks like a hospital. When my dad died last year, he was in an ICU with five other people. Those are some examples. Regulation, investment in infrastructure, less controlling the incentive of healthcare, taking more of the middlemen out of the system. And those again represent budgetary, regulatory, policy, and ideological choices. And to be frank, to be fair, if you look at that slide, not all is well in the UK, not all is well in Germany, not all is well in France. Some of the challenges of the healthcare cost are there as well. They're managed differently. Many of the systems are social health insurance systems. They're embedded in a different system of health, of delivering social services. So a lot going on. Again, I hope that's helpful, even though it's not a perfect and succinct answer to your question.
Yeah, really good idea for like a place where we could dig in deeper. There's like there's kind of a really old article. It's, the title of the article is "It's the Price is Stupid." It looks like why is healthcare so much more expensive in this country than others. This is from, I don't know, 20 years ago, and a few years ago, same authors wrote another. It's still the price is stupid. So, but one of the things I think that makes it so hard and challenging to solve this problem is that, as one of you mentioned earlier, like all the dollars that we're spending on healthcare are somebody's income. And so that's part of what makes it really challenging. So if you're thinking about like in small communities, a hospital is often the largest employer. And so it's balancing that whole, figuring out how do you achieve a better balance in that system. But also thinking about all those different perspectives. Marie, I think you were next, and then it looks like John wants to jump in too.
Yeah, I have a quick comment on the, just so nobody thinks I'm negative on the data. I think the reason that we can be so assured about data is because we have resources like Stefan and Julie's whole entire career about setting us up so we can be confident that we can dig down into data. So just wanted to dispel any data negativity. My question was also about sustainability. And I was gonna, you don't have to go into it again, but I think it is worth our time. It seems like a lot of us are pondering that. I mean, I have a 30-year-long career that started with healthcare costs are unsustainable, and yet 30 years later, we're sustaining it. So what do we think is different or will be different? Like, what is out there to lead us to think that something will be different? Because we've done it. I mean, it honestly, I worked up with a commission the very first year I was out of graduate school working on this question, and it was unsustainable then, but we did. And then my only other comment is that would be helpful to have teed up is that we've used the terms cost, spending, affordability, value, pretty interchangeable. I think they're related to each other, but it probably would be helpful if we had a discipline around precisely talking about those terms for our own sake.
Yeah, Marie, you speak my language.
Sad, Stefan, and it's not German, huh?
No. No, I people get annoyed at me when I sort of say, are we talking about cost? Are we talking about spending? I think that distinction is really important because we tend to incorrectly equate healthcare spending as the cost of care. Without getting too nerdy, the cost of production, the unit price, very different what we end up spending. That's a function of profits, investment, administration, etc. So discipline around that makes sense. And not to take up your time too much, the health department made me move my office, which was terrible because I am a bit of a collector of reports and studies, and I collected some of Julie's and her predecessors. And as I was going through the information from the 80s and 90s, these were the same topics. The concerns were the same concerns. The solutions were the same solutions. The drivers were the same drivers. So clearly, I think we have been struggling with it and have gotten better maybe at telling the story. But in many ways, I think that sets you up for really thoughtful ways of encouraging the health department and the state to come at it differently, or with a different speed or creativity.
I think we have John and then Philip and then Justin.
Great.
And then Olivia.
Andrew, your questions made me think, when I think of whole ecosystem, I have three key things. Who's paying for it, who's providing it, and who's using it. So as we think about some of your data on who's paying for it, some of it's state paid, federal paid, employer paid, individual paid, looking at the overall who's paying for care. And then back to the who's providing it, we're going to look at the cost structure to your point, what's our cost of care. But the other thing that's different, I think, in the US and many countries is the who's using it and how they use it. So a lot of those social programs, right, there are long waits, there's things you can't get. Somebody's managing your access to care much more aggressively than we have in the US. So I think as we look at affordability and the cost of our entire ecosystem, all three of those need to be taken into account. And the funding, the providing, and then the member or consumer expectations and use of healthcare.
Philip.
Different area that surprised me was, this is on page 24, slide 24, the kind of rough equivalence for the person, for the consumer, between the total individual cost of premium and deductible if they're in group coverage compared to the individual market. That jumped out at me as a surprise. And I think you were saying, Stefan, that the group coverage I'm sorry, that the individual coverage, that's sort of net after the federal subsidies. So this doesn't, my question is sort of how much different is this gonna look at the start of next year? Obviously, we have the, people who won't have coverage in a couple of years on Medicaid is a sort of separate issue, but from a affordability perspective, it seems like it would be helpful for us to wrestle with what the individual market looks like after the implementation of the reconciliation law.
Sorry, just writing down notes from Philip's comment. So one thing that I think could potentially be interesting, particularly acknowledging that there's a lot we can do as a state, but also only so much when we're dealing with within the confines of federal policy and that sort of thing, is to maybe have some comparisons to our spending to other states and sort of where kind of we're at. And then I think potentially similar to that. And I know I've seen some of this data on the MDH website, and but some of the spending broken out by sort of categories of where we're spending, and then I think also to the extent that there's the ability to look at that compared to other. I understand data from other states on some of those individual categories may not be as readily available if they don't have as good of a team working on the data. But I think that could also help in just sort of identifying where some of the most impactful policy levers could be.
It's a really good suggestion. Thank you. Olivia.
So I'm not sure if this is just a limitation, but I see data up to 2023, and here we are at almost the end of 2025. So I'm just curious, and I know it takes time to gather data, but curious when we will see like 24 and 25, because as we know, it's almost starting to be like a hockey stick, right? Like, so that would be helpful for us to kind of see more timely data. Is there an opportunity to use technology, AI, what have you, to be more dynamic in what we're going to be doing in accessing the data? And also it'd be nice if we all agreed on like a baseline time period that we would start measuring from if we take actions, right? It's always nice to agree upon, like, if we start here, what are our goals, and then what are we going to track? The other thing, I don't know if I've heard it, but I think it goes along the lines of what you mentioned, Marie, about the cost, is it savings, is it affordability? Equity stood out for me as a big one. Like, how are we addressing equity so that whatever recommendations we're making, we think about the equity. How do we make everything equitable? And yeah, so those are just my few comments.
Thank you for raising that, and also just, welcome sort of other things like, I'm really glad that you raised the equity as a consideration, and if there are other things, especially things that haven't surfaced yet, that's absolutely what we're looking to get out onto the table today. So I think we have Matt, and then Adam, and then Sheila.
I had three things more in the what's missing category. First is back in the late 2000s, Minnesota and the Commonwealth Fund and other organizations of the United States healthcare system performance consistently ranked Minnesota as number 2, number 3. For 2 years, we were number 1. Now I think we're 12th, 13th, something like that. What have other states done, going a little bit to Justin's points, not only where are they spending, how is our spending different, but how did they surpass us in terms of cost and quality? What policies have they implemented that propelled them ahead of us? The second question is, do we have data on the medical debt load that individuals and families are carrying? It's one thing to talk about their cost exposure from premiums and deductibles, but the debt that they carry is a separate affordability question and growing problem. My sense is, but I don't have the data to back that up. And then the third area is while our healthcare spending has been increasing relative to wages, relative to state budget, those kind of things. Do we have data on the amount of reserves held by nonprofit health plans and nonprofit hospital systems over the same time period? And how are those resources being deployed?
All really good questions. Thank you. Anything you want to add, Stefan, for now?
Maybe on the medical debt, we don't have direct data, but we sort of commented behaviorally by asking questions about what's been challenging, have you had to make trade-offs? Say to ask that question, well, takes work, but there's no reason to believe that what we know through national data is not the case in Minnesota. So we do have that. Yes, we have data on reserves, and we can present that. I think what's more challenging is what you alluded to, sort of like what are the strategic ways in which providers or insurance companies leverage these data, investment, community benefits, etc. So there's probably some way to think about presenting and learning about it. But yes, we can certainly contribute to that.
Adam.
Yes, so just want to reemphasize the cost versus spending data that if can be provided in the future. I think that when you compare to other states or other countries, when you talk about total spending, we could be talking about access and volume. And when we talk about like what does it actually cost to have an MRI or what are those other things? Administrative plan, those are the things that I think will be also helpful. I think they're both helpful, but making sure we talk about both is important. In a couple places, it talked about budgets, percent of budget and wage growth and things like that. Knowing how subsidy systems are set up now and possible solutions in the future, it would be very helpful. And this is what is missing to have levels of growth at different income levels, below 100,000, 200,000, 400,000. Especially when we talk about comparing wage growth and percentage of budgets, it's going to be very different for someone a household under 100,000 and compared to someone in the 1%. Let's just say it's going to be very different. And then I have a question on slide 30 with the Minnesota budget spending. The percentages are let's just call them pass-through funding. Are the funds that are sent to cities, counties, schools, and then spent on health insurance included in these numbers? Or is it just the direct fund, the direct payments through CGIP and things like that the state did?
Yeah, so I think to an extent this is related to John's point earlier to sort of say who pays. Sometimes it may be the federal government passing resources through. Sometimes it's the state spending money. There are many legitimate ways of doing it. What we have done is just to limit it to resources flowing through the state treasury. So to your specific question, yes, PEEP and CGIP spending is included in this budget.
So if a school, Bloomington is funded with funding formulas and all of that, and then they pay for their health insurance without being in PEEP, is that included?
I don't believe so.
Okay.
But to your point, sort of wanting to disaggregate data to tell a specific and maybe more powerful story, absolutely, that's something we can do and should do.
So Adam, I just want to make sure I understood your first point correctly, is that you were talking about the importance of understanding both as cost drivers, both price and utilization of care. Is that accurate or no?
Correct. I think it's important to separate those so that we understand them both. Like if group is using more care for whatever reasons. Those are the before the healthcare is access, and that is causing a higher level of use. That is good information to have. But if we're all in a situation where we can't control the first part, but we're controlling the second part, I think that's what we should know separately is how much does it cost and what can we change in that system. So they are related, but two separate.
Okay, thank you. I think on my list, I have Sheila and then Andrew, and I want to encourage others who haven't spoken up yet to make sure that you feel free to jump in. So I'm adding Laura to my list now.
So I'm here, of course, because I think healthcare costs and spending are too high. But I think it's important to also state that healthcare spending is not a zero-sum game. That anybody who has a 401k portfolio should go home and look at it and see if you are personally becoming enriched because your portfolio is invested in for-profit healthcare. This is not, I'm not making any judgment in saying any of this, but it's really important to also recognize that, well, Hennepin Healthcare, for example, is the largest employer in downtown Minneapolis. We're building tons and tons of healthcare facilities in the state. Maybe making them look too much like hotels, but it's certainly something that is lifting up the construction trades. So I'm curious about how much does healthcare contribute as an economic engine for the state of Minnesota? And, we talk a lot about the reserves of nonprofits and what nonprofits are reinvesting in the community, but also how does this for-profit economic engine contribute taxes, reinvestment in the state, technology, and so on. I think it's an important counterbalance to this notion that all spending, no one's saying here that all spending is bad, but how do we balance those two things with each other? And it goes back to what you said, Stefan, which is it's a societal decision. It's a community decision. How much wealth is enough is a really hard but important question.
Thank you. Andrew?
So I have two things. First, this kind of goes to who's using it. When we look at these healthcare numbers, are we also talking about things such as transportation to healthcare or housing programs that are under healthcare? Like what is that exactly in these numbers when we see them today? And the other thing I would like to know is how much are we investing in different categories? For example, like preventative care, how much are we investing in that? Is there a way to track how much does preventative care save us as a state if we were to invest in more in the future?
Really good question. I think a related topic that will surely come up is also the impact of primary care, right? So like having a primary care relationship and sort of it's preventive, but also like ongoing treatment for chronic conditions, the kinds of things that make sure that people don't end up in the hospital with sepsis, like we heard about it earlier. I think that's an important topic and we'll add both of those to our list.
Or on the list.
Yeah, so sort of connected to that, I wanted to zero in a little bit more on the foregone care pieces of data. It feels to me like that's a particularly important piece for this group to look at because as I said earlier, those are causing higher costs downstream, but also like this represents a whole lot of people who are experiencing costs and paying into a system that then they're not benefiting from. And I wonder about being able to access some more kind of granular data about where that foregone care is concentrated, whether that's specific regions of the state or specific sectors. There's the kind of 4 categories that are here, but I think underneath that we could probably identify where there is really acute need and be able to kind of model some solutions or ideas based on the needs of those communities.
Thank you. Stefan, did you do a study maybe some years ago about, maybe it was the cost of preventable emergency room visits? Do you feel like that's applicable here or is that a really different question?
I think, just like my
total presentation, you can bring different prisms to this analysis, right? You can ask individuals, as we've done, what did you delay care? The preventable ED visits is another angle, sort of to say, you showed up in the ED, in the emergency department for care that could have been prevented. The third one is maybe more global to sort of ask, and that's also a study a colleague of ours did about healthcare amenable loss of life. How many years of life do we lose because Minnesotans die early for something that would have been able to be treated in the effective healthcare system that we have, which probably relates to access, maybe personal choices, other things. So yeah, multiple prisms to look at your question.
So lots of good places to bring information back to y'all and dig deeper for the future. Anyone else want to jump in? Mike?
Sure, I got two, and I think this falls under what surprised me. Some of this might actually address one of the things that Sheila brought up is, I'm just surprised, given the discussions about the rise of healthcare, is that if in slide 21, the actual percentage or the share of the Minnesota economy, it hasn't changed dramatically. From my perspective, over 10 years, 13.5 to 14.4. That tells a different story about the rise of healthcare cost, unless the whole economy is growing at a rate very similar. And so I think, so the lens we look at it through, is it a crisis? Is it in and of itself a real issue, or is it tracking plus or minus? But the other one that surprised me is, if as an employer representative, right? When I look at slide 19, I would love to see this data correlated to actually the trend increases in healthcare, because I think most employers would tell you that over the last 10 years, their average increase has been significantly higher than this number here. So again, it's what data is pulled in and how it's presented is really important. So it's just establishing a consistent baseline and then understanding how it's different would be important to me.
Can I quickly react? Yeah. I think those are really good points, and I think, Olivia, your point earlier about the age of data sort of ties into this a little bit. As we talk about healthcare spending, and at least the view that I took is total overall healthcare spending. But if you look at trends in the Medicaid space compared to the commercial space, radically different. And that's the experience that, and in the individual market, that's the experience that you're speaking of. So the commercial market experience is much more worrisome, and that gets employers to talk about being stressed out, being freaked out, not knowing what to do. So definitely we can do that, and we do it sometimes. Happy to.
Yeah. Anyone else want to jump in right now? I was
Olivia asked, 'cause I think it's been touched on, but I don't know if it's been as nuanced. But you just said healthcare costs, but how do we parse that out? How do we do those different level cuts? You said transportation or other. Is it drugs? And what would be nice is over the years to see that. So is there a trend in the data of where the healthcare cost is coming from? There may not be, but it would be nice to see, is it being driven by a certain area that we should be paying attention to?
Yeah, and what I noticed is like prescriptions and drug costs isn't parsed out here, and it'd be nice to see that compared to overall spend. I mean, you think of our, on this 27% of it is our pharmacy spend, and sort of how did that trend over the years? And then how do some of these biosimilars and things that are now coming out impacting that?
Yeah, I was going to also back up to the comment that Olivia made about data timeliness and ask you a little bit about sort of what's on the sort of the horizon in terms of when we'll be able to add like, you know, I know that like there are these cycles and it can only be so timely. So perhaps you can talk a little bit about that.
Yeah. So first of all, you know, data are important. If they're recent, it really helps because people will say, well, we're dealing with a problem of several years back. And the recency of data is dependent on the source of data. And that depends on what John was saying, who pays for it. Without going too much into data, in the US healthcare system, we don't really collect data to monitor the system. Rarely. Much of the data that we use is a byproduct of delivering healthcare services. So when we look at the commercial market, for instance, with claims data, we can look at them, you know, with a 6-month delay, and we can be fairly quickly. When we look at global data across Medicaid and Medicare, you know, these systems, and Medicare, of course, maybe not surprise you, it's particularly slow, even though pharmacy claims are adjudicated like tomorrow. I guess it's on them for 2 years. So the answer to the recency of data depends on the element or the measure that you're looking at. But recognizing that and recognizing the importance of data, we monitor data historically, but we also project healthcare spending moving forward. So as part of the spending projection, again, Michelle is working on this right now. We are looking to finalize our global 2024 spending at the same time as we're projecting a 10-year horizon. Now, with the passage of the reconciliation bill, current law is changing, and building that in will probably slow us down. But anyway, so maybe we can work with Julie to give you a little bit of a matrix and a timeline, a matrix between recency measures, source of data, pair, to provide more clarity, or just tell you what's coming. A really important point.
Can I ask a follow-on question to that? So the plans are projecting 6, 7, whatever % increase in 2026. What is the recency of the data that they're using? Where are they getting it from?
I don't want to speak for them, but sort of just numerically, they're working with data 2 years back, fully adjudicated claims data, and consider policy environment, and consider sort of quarterly data, incomplete quarterly data. So I think it's a, I don't want to say mishmash, it sounds too hodgepodge, but it's a bringing together multiple perspectives, consultant data projections, modeling, but fully adjudicated data is 2 years old.
I would say we also survey employers, right? And so they're finalizing their premiums and rate setting, and then we ask them, what are your rate increases coming out as? And I would say, I think our data is just going to be coming out, but it's closer to double digits, like 9, 10% across. And then we look at it by different industry cuts, different regions, but that's how we get at our data in more real time. So they're looking at their 2025 and making, adjustments to their rates and then get their survey data to understand what is it that is coming. So it's a little more real time because they're using their own data, which is more real time from their medical and pharmacy carriers and making decisions based off of that.
So in the last few minutes that we have before I'm going to turn it back over to Alex for closing. So we just had like a really deep dive conversation about data and numbers. And we started out our day talking about individuals and stories. And I know there's an interest at MTH in asking the task force for help to kind of balance where our focus is on the stories and the data. And so sort of the question is, what is your perspective on how to balance these two things, like the quantitative analysis and the survey data versus like the actual like voices and stories from people?
I mean, I don't have a great answer to that question, but I want to get back to the name of our group, which is about affordability. And I don't know, we can parse costs and spending, but affordability adds a whole new layer, right? Because like a $5,000 e-bike is not affordable, but a $7,000 car is, so and maybe that's stories, but I think of things like how much we're spending on healthcare, and yet there's like a $2 billion wellness industry in this country. So obviously there's money that people are spending on things that they feel of value. It's a much harder, not completely based in the data, but I'm curious how, if we were going to declare success, like healthcare is more affordable, I think we first have to know, what does affordability mean to people? And I mean, some of it's foregone care, and then we bump up against this elusive sustainability, like, is it ever going to be unsustainable? Anyway, I just think that something in the story has to do with our name of our committee about affordability.
Yeah, and I think we are going to spend time digging into defining affordability. Is that right?
Yeah, and I think I just want to add to the reason we're really interested in this question of like, what does this group need? Because we could spend a lot of time on the quantitative question, and we kind of started this discussion of, gosh, data is essential and yet insufficient. And so what else does this group need, given that we are focused on affordability? And it sounds like there's some clarity and definition. There may also be, I'm just wondering about sort of clarity of like how we'll know what is our baseline, to the point maybe before, and how will we know we're being successful over time, and just sort of offering that, here's where we are today, here's where we want to be, something like that. So that's one of the reasons I'm wondering about this question.
Just a couple of quick random thoughts on that. One, I think that the stories can help. We mentioned, it was mentioned earlier that the overall rise over the last 10 years as a share of the economy isn't that significant, but stories may help us contextualize how individuals or how employers and folks are feeling that, because that may look different to them than that overall data. I also think that stories can, maybe particularly once we're getting into more of our policy discussions later on in the process, stories can be important to sort of understanding what's going on in different segments of the healthcare system. The thing I think about most specifically is we at Farmers Union, we talk a lot with independent pharmacists, and sort of, they've taught us a lot about sort of how the industry works and what's happening, and how both they feel that, but as well as how patients feel that. And so I think that's another way that stories can, help us sort of, paint a picture around the data.
Sheila.
So I'm a huge proponent of stories as a source of data. And stories in the aggregate certainly are powerful, but I think stories told in the individual context are one of the most powerful things that we can receive. And we've heard some really powerful ones today. People have shared their own personal stories, and we probably won't do that again. So I would suggest to maintain that power is to have every meeting with a patient telling their story. And I don't mean reading it, because that is different than having the actual voice of the patient. It can be recorded, we can hear it overhead, it can be in person, but it's a kind of best practice inside of healthcare now to bring a live patient story into the meeting. And it really grounds everybody in what it is we're doing here. And it may not have to be only a patient. It could be, I would limit it to patient, caregiver, and or provider, because at the core of everything we're doing, that relationship, and about whether or not those two people are being facilitated to care for and about one another. I'm certainly not opposed to hearing other stories, but I would say start with that as the core set. I think it could be really, really powerful.
Andrew.
I think it'd be nice if we are going to bring these stories, to also hear some positive stories so we know where we're trying to get to. What is, if we're trying to figure out our goal, what do we want everyone to say about their healthcare system that we know that we're being successful, make it support. It's not just the negative, it's one of the positive side too.
Yeah, I will let that be the last word for this part of the discussion and just want to wrap up quickly, sort of summarize what I heard as some of the places that you all would like to dig in deeper. So understanding more about what's spending by services and by individual payers, and sort of even underneath that, what's driving growth, price versus utilization. We wanted some comparisons to international as well as other states. There's an interest in looking a little bit more at for individuals by income level. So for example, medical debt and the burden of healthcare spending. And then we talked about preventable utilization and what would it cost to get people access to timely care so that we could prevent the really expensive and serious and dangerous life-threatening complications of those things. Did I miss anything important? Right.
We took lots of notes. I know lots of people are, so know that your voice was heard. And I just want to add a couple of things. Thanks, Julie. One is just, I heard an ask, I think the word was used discipline, and I heard it from a couple of different areas that could be helpful for this group to just have a bit of discipline. You're speaking my language. I would really like to give this group some structure so that you just don't feel like you're just kind of showing up. So that's something that I'm hearing. I'm also hearing an ask for, hey, what are the equitable the opportunities to make healthcare affordability, healthcare more affordable in an equitable way? And I just recognize that sometimes we just kind of say that, and I just want to be really to the point of discipline. What do we really mean by that? And how are we going to disaggregate data in order to really be clear with what we mean by making healthcare more affordable in an equitable way? So that's something I'm also thinking about. And just one other, we talked a little bit about stories. I did want to not forget to mention that I've had a lot of really great inputs from people sending in emails and asking for calls to just provide some input into the center and into sort of this group's work. And so I didn't want to forget to just mention one of the kind of closing lines that someone used was, "Be careful with our lives." And I just thought that was pretty powerful in reminding us that this isn't, it's about an individual and a caregiver and a clinician. And yes, the money spent is also the income earned and all of those things. But I just wanted us to remember that, yes, there is, policy to be discussed and data to be dug into, and that there just are real people that are watching. And we still have 40 some people even listening into the last 5 minutes. We've had 50 or 60 that have been listening in today. We have, people watching on TV. So just want to thank you for that and for your attention to that. With that, I want to move us ahead, Jessica, if you can jump ahead one more, just one more to where we're closing up today. All the slides recording will be available online. And we're getting together again in kind of short order in October. And I do think we're going to be, this is maybe has a little TBD next to it, but I think we'll be at the Minnesota Humanities Center, which is in Minneapolis. Again, a hybrid option. We'll try to be together in person for these first couple of meetings. So we invite folks to come back. Thanks for joining today. And also stay tuned for public hearings, public meetings, and opportunities to share in those stories. With that, I want to thank you all for your time and enjoy the rest of your weekend, and looking forward to seeing you again. Thank you.
Thank you.
Okay.
No, there's
Thank you.